Good afternoon to everyone. Yes, we took Rodwell to theatre this morning. He was under general anesthetic. What we found was, after removing the dressings, was as overwhelming as we expected. Quite a horrendous injury. This was a big trauma. Obviously the left eye was enucleated, so it was the eyeball was removed by the surgeons in Zimbabwe because it was so badly crushed and damaged. We found the maxillary sinus, so the sinus that sits in the left cheek, was fully exposed to the nose area as well, and the entire nose was actually missing. So in other words, there was a communication through the hole where the nose is. It goes right into the cheek sinus. And then in addition to that, there were minor injuries on parts of the forehead, the right lower eyelid, both cheeks, the other parts of the chin area and the neck. And then the other major area of injury was, of course, the upper lip. There's a complete absence of the upper lip. So in other words, when you look straight at the wounds, you can see the gums and the teeth of the upper jaw fully exposed. In addition, we noticed that there was a big step deformity of the lower jaw on the right side, and correlating with his CT scan. So we redid CT scans with what we call a 3D reconstruction as well, and we saw that there are quite a few fractures of both mandibles, or both sides of the lower jaw, and the ones on the left we fortunately can leave in place because the fragments have healed in a reasonably good and stable position for the jaw to function normally. Although on the right side there are a couple of areas that will require maxillofacial plating and correcting of the position. On the left eyeball area, so the eye, as I said, was removed. There's a big defect floor of the orbit, so the bony box that houses the eye was badly injured, and there's a big hole essentially into the right cheek. So we're going to have to reconstruct that as well. So it gives us a much better idea, I should say, of what the injuries are. As I said, we all anticipated something very serious, and indeed they were. We're going to stage the reconstruction. We've had to alter our timelines in keeping with what we found and the various disciplines that were there. So Dr. Razvi Ahmed, the ENT surgeon who was with us in theatre this morning, put in a tracheostomy. So that's a tube that goes into the trachea through the neck, and just in the notch above the sternum or breastbone, and that's where Rodwell will be ventilated through, and where he'll do his breathing through for now, which will enable and facilitate us to be able to better reconstruct the area around the face without hindrance. And we will have a pediatric surgeon tomorrow take him through to do what we call a PEG. It's a special tube that goes into the tummy from the abdominal wall, where he can be fed through, again allowing us to better reconstruct. And then we will do a phased reconstruction beginning towards the end of this week, possibly over the weekend, where we will do the maxillofacial work, which is essentially putting plates into the left zygoma or the left cheek area, and filling the floor of the orbit, and then also putting in a prosthetic device that will allow us to cover it with what will look like a prosthetic eye, what will look like an eye, to mimic the right eye, so that his two eyes would look similar at a glance, although they won't be functional. Though it won't be functional, he will still have vision on the right eye, of course, but not on the left. And we'll do some minor touch-ups of some of the other scarring. There's a lot of other scarring that needs to be addressed in terms of the eyebrow on the left. It's raised because of the way it was stitched in. I think because they try to compensate for areas where there was tissue loss. We have to sort of rotate some of that tissue downwards to attain a more normal position. And then the big reconstruction will probably happen during the week next week. We will have to still finalize the days, but we're going to use some tissue from his thigh, what we would call a free flap and bring that up to reconstruct the upper lip, part of the nose, and we will use the remaining part of his forehead as well to cover that nose, and then use some cartilage from his chest. So from the rib cage, we will harvest some cartilage that we'll be able to use to construct almost the support or the skeletal architecture of the nose. So all that will happen in phases, and we'll do that in stages over the next 2, perhaps 3 weeks. So yeah, I can take any questions now.
Thank you very much, Dr. Mia. I think that gives us a very good view of the extent of the injuries that Rodwell has sustained, as well as a very clear plan of what is foreseen over the next week or so, 2 weeks, as far as the surgeries are concerned. Are there any questions? I would be happy to facilitate any questions. The first question is from Norma from SABC News. There are a number of procedures you've mentioned, from the ENT putting the trachea pipe and the PED inserting the feeding tube at the top of the reconstructive injuries. Could you clarify if these will be combined operations or single procedures, one after the other?
So the tracheostomy or tracheal pipe has already been inserted this morning as part of the examination under anesthesia. We just thought it would give us better access and allow us to plan for the nose surgery better without needing an airway going into his mouth or nose. So that was done this morning already. The feeding tube into the tummy, then into the stomach, that will go in tomorrow, and that will be done as a single procedure on its own.
Okay, thank you very much. Any further questions? A second question from Norma. Are there any new technologies that will be used in any of the surgeries? In other words, innovative technologies that will be used?
I think the newest possibly technology will probably be for the left eye, where a silastic ball will actually be inserted under the mucosa of the left eye, and then that is in turn covered with an external, almost like what we call a scleral shield, like just a shell that will go over that with intervening skin. So that's something we'll do later, so that he has something that looks like an eye.
Thank you very much. Any further questions? I think the explanation was very comprehensive and very clear, but we're more than happy to take any further questions if any of our journalists have any further questions. Okay, fantastic. If there aren't any further questions, I just want to remind our members of the meet. There is another question. How long do we envisage the whole healing process to be? In other words, post-operative, what is the road that he is looking at?
I think it's a bit difficult to predict exactly, but I would say between 8 and 10 weeks complete, after all the surgeries done and, all the minor little procedures and therapy and, that sort of thing are complete. But I think at this stage of the treatment, which is the acute surgical procedures, probably between 2 and 3 weeks.
Thank you very much. Any other questions? Okay, brilliant.
I have a question from SABC. I don't know whether you can hear me.
Yes.
Yeah, Sophie Mkwena from the South African Broadcasting Corporation. I just want to find out, I was struggling with audio earlier on. How is the boy? Is he upbeat and is he coping well? And the mother?
Yes, I must say they both seem quite anxious, but he's a lot more upbeat than we expected. He's quite cooperative. He laughs at your jokes. He's very friendly and listens very attentively. He's quite well spoken, and his mom as well, very patient and very happy and very gracious. She's very grateful. Kept thanking everybody. And this morning before the op, a little bit nervous, but overall very trusting and wished us well and said we were in her prayers, and she's just very happy that this was actually possible and was very thankful to all the sponsors and everyone who's donated towards him so far. She's just couldn't stop thanking everybody, everyone who's come out to help him, and she made a point of especially thanking all the doctors and nurses this morning again. Everyone who's come to the party to look after Rodwell.
And Norma has just posted another question, Dr. Mia, and that is based on the pro bono aspect. Would it be possible to make an estimate of how much such an operation would normally cost?
I would have to check with the hospital management exactly at this stage, but I would think that theatre time and equipment and the specialists getting involved. I mean, we had specialists and anesthetists and three medical specialists, including myself, and then the pediatrician as well. So I would imagine this. The bill already from the last couple of days of being in hospital is already way above 50,000, almost 100,000 rand. To be honest, I think that estimate will grow as the days go by. Remember that he's already being kept in an ICU setting at the moment. So unfortunately the expenses will be going up quite a lot, and as the operations become longer and more complex and all the equipment being used increases, it will increase quite a lot. I must admit I'm not au fait with all the various costings and medication and all that sort of thing. So I think I'd have to consult with hospital management and
I think
put something together.
Yeah, I think at this stage it is. It suffices to say that this is a very complex situation, very complex operations, and that the cost under normal circumstances would be substantial. And that is why the pro bono contributions of the team involved, the hospital, also the donors that have actually contributed through the donation drive as well, is really substantial. And this is a life-changing operation that a lot of people have come to the party in order to enable this, and it's such a kind gesture. Yeah. Okay, any other questions? Okay, fantastic. I think just a few arrangements to also reiterate before we close. The first thing is, unfortunately, at this stage, we cannot give access to Rodwell and to his mother, obviously, for two reasons. The one reason is obviously patient privacy needs to be respected. And the other reason is we are in the midst of the COVID-19 pandemic, and we cannot risk infection to the patient, to anybody else in the facility, but also we cannot risk infection to our members of the media. So we please ask that you traffic any media inquiries regarding this case to ourselves. You can either use my direct email address, which I use to invite you to this media briefing, or alternatively, you can use media@stone.consulting with nothing after the consulting. It's just media@stone.consulting. And we'll be able to facilitate further media inquiries to Dr. Mia and to the Mediclinic team as appropriate.